Perfect. So let's get started. I think, I don't know if everyone knows me, but I'm Maj Grenier and I work at Cartier, so I'm the periodontist there. So today our subject's gonna be the cannabis. It's gonna be a little bit more about cannabis and periodontitis, but you will see that I did try to cover maybe not everything, but most that you need to know about cannabis and dentistry. So let's start. So first, cannabis has medical and recreational purposes, and it's one of the most common recreational drug used in the world. So it has been legalized in the US in 2015. There's 24 states that have legalized it for medical use and 4 states for recreational use. So in Canada, we legalized it for medical use in 2001, and recently in 2018 for recreational use. So the prevalence. So Canada is among the highest used in Western country. So they did a survey in 2017, which is before the legalization, and they found out that about 15% of Canadians age 15 and above report using cannabis, and a little bit more the male than the female. So I think if we would do the survey today, it would be higher because it's now legalized. So there's another study that looked at the cannabis used among adult cigarette smoker, and they looked at it in 4 different countries, and I think it was interesting to see that the use of cannabis and cigarettes, Canada comes first among those 4 countries, and when we talk about daily cannabis use, we come second, so pretty high. So what about Quebec now? So it's the 8th in the Canadian province. So again, adolescent and young adults represent the largest group, and it's a little bit more occasional smoker, but it's 30–40%, so pretty equal. Then cannabis, so a little bit of background. So it comes from a plant. So there's 3 different kinds of plants. So the most popular is the sativa because it has a high concentration in THC. So we'll talk about THC, CBD in a couple of slides. So you'll know a little bit more what it is, but it's the main ingredient in the plant that we want to have the effect of. So the second one is the indica, which has a higher level in CBD. And then you have the ruderalis. The level of THC and CBD are too low, so we don't really use it, but it's easier to grow, I think, and they want to mix it with the other plant to be more productive. So from those plants, then they can do products. The most common is the marijuana, and usually this is the less concentrate in THC. And then you have the hashish and the hash oil. So after that, the consumption methods. You can either smoke it, mix with food, take it orally with capsule oil. There's some gel and there's some spray. And maybe there's other method that is not there, but that's the main one. So now you think, okay, is it better to smoke it or ingest it? So you can do both. But if you do smoke it, there's a little bit higher prevalence of severity of oral pathology. And you'll see during the presentation that it might not be because of the ingredient, the active ingredient, but maybe because of the smoke, the heat, and the other product. So we'll touch on that later. So smoking cannabis, when you do smoke, you will have about 50% of the THC that is inhaled, and then half of it is exhaled. So your lung will probably absorb 24%. And it seems that when you decide to vape, you lost less the THC. So the effect, if you smoke or ingest it. If you smoke it, usually it will be pretty quick, second to minutes. But if you ingest it, it might last a little bit longer, 4 to 12 hours. But both can persist for up to 24 hours. So the composition of cannabis. So there's about 460 known compounds called cannabinoids. So the cannabinoid, the term cannabinoid, you need to kind of remember that because it's going to come back in the presentation quite a bit. So there's 60 unique to the plant that contain the primary active chemical. So this is the THC. So you don't have to remember that big name, but the THC, when we will look at study, it will always come back. Perfect. So the term cannabinoid, what it is? It's a group of molecules that will act on the cellular cannabinoid receptor. It will be important here because they're divided into 3 groups. So this is really important to understand. So the first group is the endocannabinoids. So those ones are produced by our body. So big name again, but if you can remember, but I will tell you again, but the AEA and the 2-AG are the two most popular or known endocannabinoid so far. Then you have the other group, which is the synthetic. So we will only have like one slide on the synthetic, and we will not talk about it that much. And then you will have the phytocannabinoid, which come from the plant. So two big name again, but the THC is the main one, and the CBD is another one. And there's another one that I will talk later, but we don't talk about it much. So let's start with the first group, the endocannabinoids. So sometimes you'll see the abbreviation like EC. It's a class of lipid mediator. So it is synthesized on demand by our body. So it is released by either membrane diffusion or membrane transporter. And after that, those molecules activate the cannabinoid receptors. And the purpose of all that in our body is to try to maintain the homeostasis. So the EC or the endocannabinoid, they do modulate a lot of things. So they can do proliferation and apoptosis of T and B lymphocyte, inflammatory cytokine production, immune cell activation and migration. The effect here, like I did try to use like a color code in my presentation to make it a little bit easier. So when it's yellow, it's just information that I think are like more important, or it's easier for me like to present with that. But the blue will be kind of the effect that will help for periodontitis or like oral disease and all that. And red will be more like when it will be detrimental. So maybe it can help a little bit. So the endocannabinoid, usually they have the effect of immunosuppressive and anti-inflammatory, which can be good for periodontitis. And then the EC system, so all that, in medicine, there's a bit more study, and it's a new target, that system, for the research to try to find molecules to help and create medication for many diseases. So there's way more literature on cannabis and other disease than cannabis and dentistry. So the second group, the synthetics, so they call it either spice, K2, or synthetic marijuana. It's 100% chemical, and it's not detected in the urine screening. So it might be more popular with the military or the police or people that really need to get tested if they really want to use it. They have similar effect to cannabis, but they are more intense because the bound is like stronger with the receptor. So Cb1R and Cb2R, those are the cannabinoid 1 or 2 receptors. So that will come pretty often in the presentation too. And the effects are faster and shorter if you compare it to like the regular cannabis. That's about it for synthetics. So it was just like a little bit of information. Then you have the phytocannabinoids. So I already told you about the THC. So that compound has the highest psychoactive action. So when we talk about like having a high, the THC induces like a high. The CBD doesn't induce a high or euphoria, and has no psychotropic property, and maybe sometimes is there to counteract the effect of the THC. And there's another one, the CBN. If you read a lot about cannabis, like you might see that one, but it has low psychotropic properties, and it's not really like I didn't really see it in the study that much. Then after that, like endocannabinoids, phytocannabinoids. So the endocannabinoid signaling is associated with the activation of several receptors and modulation of key enzymes, with which maybe the phytocannabinoid that comes from the plant can interact, and if they do, it might disturb like the endocannabinoid system homeostasis. So the question mark is that you'll see there's a lot of question mark in my presentation, is that there's not a lot of research and not a lot of research on mechanism of action. So it's a lot of hypotheses that we will see, okay? Although like they know like the three-dimensional structure. They don't know all the structure. They know like a part of it, and there's still several to elucidate. And the more they know, the more molecular medicine they can try to do to cure some disease. So because of that, it can be really difficult to really understand the interaction with the phytocannabinoid and the real impact, because the endocannabinoid, it's like in our body. But what happens if we kind of add like a phytocannabinoid on top of it? So there's other thing in cannabis. So there's the non-cannabinoid constituent. So if you compare cannabis and tobacco, each product can produce about like 4,000 chemicals when you smoke. They're similar, but with my reading, I really understand that the pharmacological activity differ, and doesn't mean that it will do the same effect. So the difference with the cannabis compared to the tobacco is that in the cannabis, you have like the presence of cannabinoid, that the molecule, and you don't have any nicotine. So that's the difference. So let's talk a little bit about the endocannabinoid system, the system itself in our body. So it has been discovered in 1990, so I think it's pretty recent. And it does include the receptor, like I said earlier, the Cb1 and the Cb2, those are the receptor, as well as like several enzymes and ligands. So those receptors, so they know the 1 and the 2, so the Cb1 receptors are found in cells which mediate more like the psychotropic effect, analgesic effect. And they're found mostly like in the brain and the central nervous system. If now we looked at the Cb2 receptor, it's mostly in peripheral organs, and it's more associated with like the immune system. And it might have a role in regulation of bone metabolism. They're not too sure, but yeah. So those receptors, the resolution, like the structure, the high resolution crystal were discovered only in 2016 and 2019. But now that they know that, it might allow for the development of new like modular that can help for many diseases. So there's a lot of like research and literature going on that. Pretty like a new subject in a sense. So the THC now, the THC, like you see at the bottom, like there's receptor and they are agonists to those receptors. So they fit in the receptors and they bind to usually the CNS receptors, and it can influence like a lot of things. I'm not gonna list all that. But the CBD does not directly fit the receptors. So you can see that it can bind like on the side, and it can have like powerful indirect effect because like they can avoid the THC to bind. It's still being studied, and there's a lot of effect like anti-inflammatory and all that for that. So that was a bit more about like the general. Let's now jump on like the cannabinoid and the periodontitis. So a lot of question mark again. So there's conflicting result about like the effect of the cannabinoids of the cannabis on bone resorption and osteoclast function. Like I said, we don't know exactly how it works. There's a lack of study, of course, and there's a lack of methodology in the study. When you review the literature, it's really important that you kind of read the article. You need to see, is it an in vivo or an in vitro study? And are they testing or looking at the endocannabinoid that are produced by a cell, or they're talking about a phytocannabinoid? Because if you don't do that, and you'll see later, because we're going to look at a few articles, but if you don't do that and you just read the conclusion, then it doesn't make sense. So I'll try to make it a bit more clear for you today. So a really quick review of periodontitis, just because we're going to talk about it. So we know that it's a chronic inflammatory disease, and the primary etiology is biofilm. It does destroy the periodontal tissue, which leads to loss of teeth. So really basic. Here, I did put that little pyramid at the bottom. So most of us know it with all the bacteria, and you have the red complex, which is more associated with periodontitis. Because in the article that I'm going to present, they're talking about Porphyromonas gingivalis. I did want to do a little review. So PG, like it's easier, it's in the red complex. It's one of the main bacterial pathogens. It's a gram-negative anaerobic, and it has a lot of virulence factors, but one of them include like the LPS, lipopolysaccharide, and those LPS will stimulate the host immune cells to produce pro-inflammatory molecules. So you need to kind of remember that. So when you have like periodontitis, you have a pro-inflammatory molecule which induce several cellular reactions. And then you have an inflammatory status, and with that status, start destruction of connective tissue and osteoblastic bone resorption. But at the same time, our body tries to protect like the bone and all that, so it prevent pathological outcome of pro-inflammatory insult. So all that, like we want to have a balance between the pro and the anti-inflammatory, because if you don't, or it depends of that balance, like the progression and the severity will depend of that balance. So the immune response in periodontitis, it's aimed to destroy and eliminate the periodontal pathogen, but at the same time, if the response is excessive, then it will lead to like tissue destruction, which is not like ideal. So periodontitis has a really strong genetic component, but it's also affected by environmental factor and behavioral factors. So then you'll see that the literature on the association between the cannabis use and the periodontitis is sparse, but it's better than a lot of other things in dentistry. So let's start to review like the article. So we will start to look at article that check the endocannabinoid, their effect on periodontitis. Okay, so in general, the endocannabinoid system is recognized to modulate immune response. So we said earlier that the EC promote anti-inflammatory response, which would be good, and immunosuppressant response, which could be good for periodontitis. So they said that regulation of cytokine production by EC might, so we don't know, but we think that it might play an important role in balancing between bacterial clearance and the tissue destruction in periodontal disease. Like I said, it's an hypothesis. So possibly they said that if there's some bone destruction on all that, it might be because the bone remodeling overlap in periodontal tissue, contributing to an increase of periodontal destruction. So they don't know, but they think it's that. So they said that an association between the endocannabinoid system and periodontitis is possible, and it's mainly remain unknown. But we'll see. There's a few things we know. So let's start with one study from Nakajima in 2006. So it has been done in vitro, so that's important, and it's looking at the endocannabinoid. So usually it's on like cell and the system. So their hypothesis is that the LPS, like the virulence factor of PG, will stimulate our host cell, and they will release the endocannabinoid in the periodontal tissue. So they don't add like phytocannabinoid and all that, like it will be released by the cell, which may reduce the excessive production of pro-inflammatory molecules, so which would be good because they will activate the receptor and do like protective like. So what they did found after the research is that the gingival fibroblasts that they use, like in the lab, they do express those receptors. So that's one finding. And then after that, so activation of the immune cells in response to the LPS or other like pro-inflammatory stimuli, they also upregulate the expression of those receptors, which could be good because then you'll have like a lower inflammation. In that study, they said that there's also like contradictory result indicating like the downregulation of those receptors. But if you read carefully, they say that it might be due of a difference in the cell type that they do use. So they may be using different cell types. So the result can be really different, or the stimuli. So you will see that one is like if you smoke it, if you inject it, there's always like a big difference in the result. So let's keep going. So the AEA, like we remember, is one of the endocannabinoid. It's always dose dependent, so that one can reduce the production of pro-inflammatory like mediator. So it does indicate the involvement of cannabinoid receptor in mediating the anti-inflammatory effect, which can be good. And they did see like a significant upregulation of the receptor in the cell, like HGF. It's like the human gingival fibroblast, so the cell that they did use. On patients with gingivitis and periodontitis, if they do compare it to healthy patients. Okay, so healthy patient, maybe there's not much going on with the endocannabinoid system, but when you have inflammation, then it does activate the endocannabinoid system. So their conclusion is that, again, like the AEA and its receptor are present in the periodontal tissue. The cannabinoid system may be protecting against excessive inflammation, which can be good. So this is for the first study. There's another study from Özdemir in 2014. They kind of did something similar. So it's in vitro, and it's the endocannabinoid too. So when you read an article, there's always like an introduction, and you have like the review of findings, and they talk about like the other study and what we know and what we don't know. So in that study, like I will point out a few things that was in the introduction. So well, they said still in 2014 that the periodontal disease associated with the endocannabinoid, it's still unclear. So the other one was, I don't know, 2006, and in 2014 it's still like unclear. So we were talking about ideally each study would use the same like a cell. So one of the most popular cell is the human periodontal ligament cell. So why? But those cells are an element for the homeostasis of the periodontal ligament. So if we destroy those cells, then we will induce like destruction and periodontal disease. So those cells are widely used for stimulation of the in vivo conditions. So it's not maybe all the study that use those one, but this is one of the most popular. So now, again, the AEA and the 2-AG, the two main endocannabinoid, they said that yes, it's detected in periodontitis patients, which like goes in line with the other study that we just saw. And they said that it's not detected in periodontally healthy patients, which still goes in line with the other study. So the AEA level will reduce in a patient with periodontitis after a surgical periodontal surgery. So a patient that has been treated for periodontitis, which is good. But in their finding, they said that the 2-AG, which is the other one, remain unchanged. So you'll see later that the 2-AG is a bit more controversial. So in study in vitro, the AEA seems to reduce the production of pro-inflammatory mediator and promote like the proliferation or viability of the fibroblast, which is good. In animal studies, the AEA still like reduce the inflammation, which would help. So the aim of the study now, so we're done with the introduction in that study. The aim of that study was to examine the effect of the two endocannabinoid on either like the proliferation or the viability and the cytokine chemokine production of those cells, the periodontal ligament cell, in the presence and absence of PGLPS. So it seems complicated, but we'll see like the result. I did try to arrange it a way that it might be a bit easier to understand. So just a really quick review, because we're talking about interleukin, and sometimes, you know, we don't remember those one all the way. So really quick, interleukin 6, it's a multifunctional pro-inflammatory. That's what you need to remember, cytokine. And it has a significant role in inflammation and stimulate the osteoclastogenesis and bone destruction. So the 8 now, it's one of the most important chemotactic factors of PMNLs. So it is produced by those cells, and their level increased in presence of PGLPS. And then you have the MCP1. Those are all like pro-inflammatory that are like listed in the study. So that one is a chemoattractant for macrophage. So those 3 are pro-inflammatory. That's what I want you to remember. And then the conclusion of that study. So here, the first point is like, if you have absence of PGLPS, so more like a little bit more healthy patient. And the second one is when you have a presence of inflammation, so PGLPS. So let's come back with the first one. If you don't have any like inflammation from PGLPS, then the 2 endocannabinoid, AEA and 2-AG, they have no effect on proliferation and viability of the cell, and no effect on the pro-inflammatory like molecular expression. The only thing is that the 2-AG has slightly enhanced the interleukin-1, and that is a little bit more controversial. So we'll see. Then after that, if you have the presence of PGLPS, then the AEA will increase the viability of the cells, and it will downregulate the pro-inflammatory, so which can be good. But the 2-AG, then they found that it significantly upregulate the pro-inflammatory expression. So I think they're talking about it later. So their conclusion is that the AEA appear to have an anti-inflammatory and immune suppressive effect that goes in line with what we were saying since the beginning. But the 2-AG appear to promote detrimental inflammatory process. So they say that that finding is more controversial. It might be true, like there's a lot of things we don't know, the way they interact and all that, but it doesn't come back a lot in the other study. So their conclusion is that the EC are not able to induce the pro-inflammatory response, but it can affect the pro-inflammatory signaling and modulate the inflammatory response. So another one, really quick with that one, it's just a little bit more recent. So ABD did one study in 2017. It's still in vitro and still endocannabinoid. And it just said that the target for intervention in periodontal inflammation are the receptor that we know. And they just said that maybe the CB2R is more particular because its level increased during inflammation. And they said that they are effective. There's an effective inhibition of those pro-inflammatory molecule production by the receptor ligands. So they just suggest that targeting the endocannabinoid system might lead to develop some new drugs for periodontal therapy. So now we're done with the endocannabinoid and periodontitis. So what we understand from that is that our body will probably produce those ones to try to create an homeostasis or help like for periodontal disease. So now let's start to review the literature a little bit more about the phytocannabinoid, the one from the plant, and their effect on periodontitis. So mechanism of action, big question mark. We don't know. How do they work? So those are hypotheses. So it can be just the poor oral health from cannabis user, can be chronic inflammation of the oral epithelium. It can affect the alveolar bone by increasing bone loss, but how? Maybe, I don't know, the rank key. So they said that they have limited knowledge on the mechanism, on how they have detrimental effects. So the first study that I wanted to present is Napi-Moga in 2009. So now we start with the in vivo study, and it has been done on rat. So their methodology, what they did, the periodontal disease was induced by ligature. So like you can see on the little picture. So they had 3 groups. So one was the control group. The second one was the the ligature, like periodontitis induced by a ligature with a vehicle which was neutral. And then you have the third group, the ligature and the CBD. Here, what you need to read is that the CBD was injected to the rat, because you'll see the result will be really different. So they did that for 30 days, and then they killed the rat, and then they analyzed it. So the result is that the group with the literature and the CBD, they saw a reduction in alveolar bone loss, which is good, and in the reduction in the neutrophil migration associated with lower pro-inflammatory. So this is really good. So the conclusion, the CBD might be useful to control bone resorption during progression of experimental periodontitis in rats. Okay. But now let's do another study. What if our rats start to smoke? So Nogueira and Philho did a study in 2011. So they did again a study in vivo on rats. So, but the rat was like was under like with the smoke. Okay. So inhalation of cannabis in rat with and without teeth with induced periodontitis. So they saw bone loss was greater in the teeth with the periodontitis, so not good. They didn't see any difference in teeth without periodontal disease, so stable. Okay, so they said that the cannabis did not start the bone loss, so I think that's not obvious, but like that's not the main etiology, but it does increase the loss when it's present. Okay, so now we start to see that smoking cannabis might not be really good for the gum. So now let's start to see one or two studies on humans. So Sharif in 2017 did one study in vivo on human. So the aim of the study was to try to see the relationship between the frequent recreational cannabis user and periodontitis prevalence in adults in the United States. So what they did, so they used the data from the NHANES from 2011 and 2012. So again, before it has been legalized. But they had quite a bit of participants, pretty equal between male and female. And what was really good in that study is the group age goes up to 59 years old. So in that group age, they're more risk of having periodontitis. So you'll see in other studies, sometimes they do this on like adolescents. And they looked at covariate, like a lot of covariate and a lot of risk factor, which was good for that study. And they look at history of periodontal treatment and all that, okay? So how did they assess the periodontitis? So they did proving that and clinical attachment loss. It was a series of data, but those data were obtained from a real examination. So the examination was done. It was done with the 6 sides per tooth for all teeth, excluding the third molar. So they used the CTC and the AAP definition of periodontitis, which is like more common in the literature, and this is a really good definition. And if all the study would use that, it would be easier to compare the results. So here I'm not going to go in detail on that, but with that classification, it's divided in 4 groups. So severe periodontitis, moderate, mild, and no periodontitis. Will it change now that we have the new classification in perio? Well, maybe, maybe not, but that's not the point of that presentation. So this is something they use to assess the periodontitis. And then how did they assess the recreation, the use of cannabis? In fact, it's almost all the time self-reported use, which is okay. But here, if you look at, if they said a frequent recreational cannabis user, it's 1 or more per month, which I think is not a lot, but still. And non-frequent is less than 1 per month in the last 12 months. So you have to look at it too when you read a study, because maybe another study will have another definition for that. So that study has strength and limitations. So they do have a large data set, which is good. They have a good full mouth examination, and the group age is really good. The limitation is a little bit more the selection bias. So maybe they had to exclude the chart that the information were not complete. So it was maybe a good candidate, but they didn't have all the information, so they couldn't include those one in the study. And the fact that the cannabis use is self-reported data, so maybe it was under-reporting. But their conclusion is that 26.8% were frequent user. Of all frequent user, about like 40%, which is pretty high, smoked tobacco too. And among all the covariates that they looked, tobacco was the only co-founder. So they had to do an analyze of the relationship on people that never smoked, just to see what was the effect of the cannabis on periodontitis. And the frequent user were like twice as likely to present with inferior periodontal status still. Okay, so they said that frequent users were associated with deeper probing depth, more clinical attachment loss, higher odds of serial periodontitis compared to the non-frequent user. So after that, in their discussion, so like I said, usually there's an introduction, the methodology, and all that. At the end, there's always a discussion, and they do compare their data with other studies out there. So here, what they said is that their data concur with the existing literature, in the fact concur with 3 humans, so Thompson, Mayer, and Jameson, and 1 animal, one that we already saw. And all those studies said that they report a detrimental association between cannabis and periodontal status. However, it doesn't concur with the 2 studies, and you'll kind of see why, I think, but 1 human and 1 animal, because those 2 failed to document such an association. But let's review all them really quickly, but let's see all those studies, okay? So Thompson and al. In 2008, they said that cannabis is a risk factor and it's independent from the use of tobacco. So cannabis and tobacco smoker are twice as likely to have periodontitis versus cannabis smoker only. And they did like say that cannabis and tobacco had a synergistic effect too. So I'm not gonna go into all the detail for that study, but it does concur with the other study. So Mayer, same thing, in 2016, their conclusion is that cannabis use for up to 20 years is associated with periodontal disease. And you see, like it's always like smoke, like it's not injection or endocannabinoid. So Jameson said that the substance use has been linked with periodontal disease. It's in Australia. And they say in 2010 that the role needs more investigation, they didn't know. So that one we already discussed. So yes, the cannabis like increased the loss when present. And then Lopez in 2009 didn't have that association. But when you look at the study a bit more in detail, the population was on adolescents. So I don't know. The prevalence of periodontitis in adolescents is pretty lower. So that might be a reason why their conclusion is that there was no evidence to suggest that the use of cannabis is positively associated with periodontal disease in this adolescent population. So that's why we need to be careful to say, oh, like there's so many conflicting results. And then the other study, it's our rats, but it was about CBD and it was an injection. So not smoking cannabis. So they said that CBD might be useful to control bone resorption. But when you read the discussion of the other study, if you don't know those details, it can be confusing. So after that, not to conclude the presentation, maybe the part of periodontitis and cannabis, it's good because we have like a meta-analysis that was done by Chissini in 2018, so pretty like recent. And a meta-analysis is like gathering a lot of study, going through all those studies, and just keep the really good one with the good methodology, the one that you can compare, and you do an analysis, and then usually the conclusion of that analysis is pretty strong, like it's the stronger study that you can have. So at first, like in the introduction, they were talking about all the limitation of not that study, not that meta-analysis, but the study in general. So they say that yes, the definition of periodontitis should always be the same. The use of cannabis was self-report. So the gold standard would be to really do laboratory tests, but it comes with a high cost and it might have like ethical reasons. So usually they do self-reported, but they could maybe do like a standard question or have like the frequent user always the same. Like that, it would be easier to compare the result of all those studies after. And plus, with the self-reported, then maybe the result could be underestimated. So they also say that use of tobacco is really high among individuals that use cannabis. So they did say that it was a confounder, like we already said earlier. And they suggest that the mechanism of induction of periodontitis may be different between tobacco and cannabis, and it's really hard to differentiate. So, because we know that tobacco smoke is a well-known risk factor for periodontitis, but there's a lack of data on cannabis. So for further study, they do recommend that they do different groups, smoker and non-smoker, and they do like stratified analysis by these groups to be able to understand a little bit more the effect of each. Then about like the bone loss, the cannabis and the bone loss, the pathway through which cannabis acts in destruction of periodontal tissue is still not clear, and this is in 2018, and they said that there's still like contradictory results. So if we come back to the meta-analysis itself, so at the end they did that with 4 studies, and those studies are those one, and we already discussed the 3 first one, but they add another one. So those are pretty good study on the subject. So Ortiz and al. In 2017, they did a study on like a pretty good group of adults, and they did interview, periodontal examination, and they were looking also at the HPV sample. Okay, that's the difference. But they used the NHANES methodology, which was good, the CDC-AAP definition of periodontitis, which is good, and they did find like an association between the periodontitis, but nothing with the HPV. So that meta-analysis did the analysis, and then the result, they found like a positive association. When the prevalence ratio is higher than 1, you do have a positive association. So for me, now it does convince me to like talk to my patient about the effect of cannabis on periodontitis. So I'm pretty confident. So that concludes like not the presentation, but the cannabis and the periodontitis. So this is what we have on it. So let's just check a few other things because we're not all periodontitis. So cannabis and general oral health. So the effect of cannabis. So different factors can play a role. So it depends on the drug potency, depends on the concentration of the THC that you have. It depends on other cannabis constituents here. So the toxic byproduct by smoking, the tar, the carcinogen, the way of administration. Do you smoke it, vape, ingest, and how frequently you use it? Do you use it occasionally, regularly, or daily? Here they talk about, I read some information about like exposure of cannabis compared to tobacco. So usually people will smoke cigarette more, but they say that there's more frequent exposure with cannabis because they explain it by the fact that the person will take larger puff volume, they will have larger inhale volume, and they will try to keep it inside like longer. And plus, they said that there's a higher combustion temperature if you smoke cannabis versus tobacco. I also found that the concentration of tar and carcinogen are higher in cannabis, but when I was reading on the subject, well, it was a little bit controversial because there's not a lot of study on the concentration of tar in cannabis. So maybe that's, I wouldn't say that like, oh yeah, the concentration of tar is like way higher in cannabis. There's another thing, I'm not going to spend too much time, but I think it was really interesting in one of the articles that I read. So they said that the THC smoke should exert a protective effect against pro-carcinogen. And if you look at the nicotine will potentially like increase the carcinogenic effect of tobacco smoke. And they were explaining that on like the pharmacological, the way they act with the receptors. So it was a bit complicated, but I think it was really interesting to see that both like doesn't act the same way. So there was like another study in 2008. They did a review of the effect of cannabis usage on the oral environment. So this is just a list of the effect that was in that study. So you can see xerostomia, oral cancer, infection with Candida albicans, gingivitis, periodontitis, we already covered. And then so this is like a literature review. It has been sent by Ottawa. I did receive it like a couple of months ago. And it has been done by Dr. José Lanza from University of Toronto, but it was done for the Office of Chief Dental Officer. So if you really want to read one thing, I would recommend that you read that article. I did review or resume that article in my presentation. So if you read my presentation, it will cover everything. But this is a really, really good review, and it was done in 2020, so really recent. So what they were talking about? So they're talking about cannabis smoke induced xerostomia. So they said that it's one of the most commonly observed adverse effects. And when you smoke, the effect can last up to 6 hours after you smoke. If you vape, some studies show that it can cause xerostomia, but like there's not a lot of evidence, but it probably causes xerostomia too. And what about the cannabis in prescription? We'll talk about those medications a little bit later, but those pills are associated with the xerostomia too. So then cannabis smoke and saliva. So yes, it does alter the chemical composition. So it would reduce the pH and the phosphate concentration, and it would reduce like the buffering properties. So, and it can also reduce like the secretion. So because of all that, it could augment the risk of oral pathology. What about dental caries now? Because of, well, the xerostomia, the reduction of the salivary pH, the promotion of plaque and calculus formation, and other things like maybe the cannabis user will have poor oral health, will less brush, less visit his dentist, and maybe have a higher cariogenic diet. Because of those reasons, they said that there's higher risk of dental caries with those smokers. Oral cancer, that's a little bit more like we don't have a lot on that because like 90% of cannabis smokers also smoke tobacco. So the percentage is not always the same, but you will understand that a lot of cannabis smokers do smoke tobacco. And we know that alcohol and tobacco are associated with the head and neck cancer, including like the oral squamous cell carcinoma. But the relationship between cannabis and OSCC is really unclear. So I wouldn't say that there's a lot. There's other thing in that review that they said, but it's less frequent and it's not really study that has proven that, but they have associated like stomatitis, gingival hyperplasia, but it's really an association. There was not a lot of study about that. Leukoedema, uvulitis, and maybe pre-malignant lesion with the user of cannabis. So let's look a little bit of the relation between cannabis and medicine. So cannabis do have systemic effects that are relevant to oral health professionals. So we'll see them a little bit one by one. So cannabis and cardiovascular. If you're a heavy or a regular cannabis user, there's probably more risk of stroke, myocardial infarction, cardiomyopathy, arrhythmia, cardiac arrest. Then for the cerebrovascular, so if you do use cannabis, maybe you have a higher risk of acute subarachnoid hemorrhage. And we will talk later what can be a little bit interesting for us, that maybe that risk can be augmented if we do use epinephrine, but we'll come back on the use of epinephrine. And also cannabis will elevate the vascular tone, create some vasoconstriction, augment the plaquette aggregation, and maybe can lead to an augmentation of acute ischemic stroke or transient ischemic attack. For the gastrointestinal system, then we said that cannabis causes xerostomia. It can reduce the gastric acid secretion and mobility, reduce the visceral sensation, and reduce the inflammation too. There's one thing maybe we need to know. I didn't know before I started to read about that, but there's a condition. They said it's an emergency condition on people that use chronic cannabis. It's called cannabinoid hyperemesis syndrome. So what the symptoms, like the patient will have severe and cyclic nausea and vomiting, and it's gonna happen really quick. There's not a lot of treatment. They said that if patient take hot bath, it will help to reduce the symptom, but what they need to know is to stop using the cannabis. But if you see that on a patient, well, at least you'll know what it is. Okay, now, like I said, I did focus my presentation on cannabis and dentistry, but there's a lot of literature more on cannabis and medicine. And cannabis is used for a lot of disease like chronic pain, multiple sclerosis, and there's a lot of study that I did not read all. But I said that we were going to come back on the medication on the market. So maybe there's more, but there's like 4 main one. So the first one is nabiximol, so it's called Sativex. We'll talk about that one because it does, and we'll see, like it's about the mouth, so we'll talk about that one. Then you have the drobarriol, mannitol, the nabilone, the Sesamet. Those 2 are used to control vomiting and nausea in oncologic patients when the regular medication doesn't really work. And you do have the CBD oil, which is the Epidiolex, and it's used in pediatric epilepsy condition. Same thing when the usual drug doesn't really work. So you have to know a little bit that if it's on the medical questionnaire, at least you'll know a little bit what it is. So let's talk about a little bit more the Sativex. Scully in 2007 did a study. It's not a really good study, but you'll see that it's interesting for us because there's only 8 patients. So it's a study in vivo on human. So because the Sativex actually it's an oral mucosal spray. It does include like the THC and the CBD, and it is in 50% of alcohol in a propylene glycol base. So that might be important. And they can use up to 48 spray in 24 hours, which I think is pretty high. And they use it under the tongue or on the buccal mucosa. And they use it to relieve pain in multiple sclerosis. The Sativex has like oral side effects, and the 3 main ones are oral burning sensation, stinging, and white lesions. At least 5 RTC. RTC is like it's just a pretty good study. So there's 5 that confirm good study with good methodology. So 5 confirm its efficacy to reduce pain and sleep disturbance for multiple sclerosis. And it can also be used for the analgesic effect on rheumatoid arthritis patients. So it's probably used out there like quite a bit. I'm not too sure, but it's pretty, it's possible. And it's available in Canada, so since 2005, and they can have it in the pharmacy. But it's a controlled drug for sure. So their study include only 8 patients, but the patient had to use the spray for a minimum of 4 weeks. They did an oral examination. They asked for any symptoms, and then if lesions were recorded, the patient had to stop using the spray for 4 weeks, and then they did another evaluation. I did include the table here that was in the study just because I want to point out that all the effect, the comment, it's always maybe. So you can look at it if you want. So the result, all patients had the stinging sensation, but none of them report dryness or bad taste. 4 of them had visible oral white lesion in the floor of the mouth. And they said that it was resembling more like a keratosis or a burn because they didn't do any biopsy. So in their discussion, they said that they think that it was burned because most of them, I think all of them, were either resolving or improving after discontinuation of the medication. So they're thinking, well, it might be the high alcohol concentration that is like the problem. So they just do recommend to do regular inspection and maybe move from a non-alcohol formulation, which I'm not too sure that it does exist so far. But I was thinking about it, and there's even like a lack of evidence implicating alcohol-containing mouthwash with oral cancer, like today. So we don't have a lot of like evidence on that. So it might not be, we cannot really say that it's a big issue. Okay, let's now talk about cannabis and sedation. There's no study like in dentistry, but there's some study in medicine, and maybe those results will help us to understand like the effect. So Douglas did a study in 2005. It was a review, and they find out that cannabinoid can prolong anesthesia. Depends which one you're using, but with those three at least. So, and they said that it may also interact with other agents because of the metabolism in the liver. And they also said that that interaction may persist for a long time or could be initiated even days after consumption of cannabis. And why? They said that it's because of its lipophilic nature of cannabinoid that delays their clearance. It depends the way you use it, and their elimination half-time will increase if you're a regular or heavy smoker. In that same study, they tried to give us some effect of the cannabis on the cardiorespiratory dynamic. So they said that some effect of the THC in human can be an acute tachycardia. So that one like can be a little bit more important. Like if you do smoke, then right after you can have acute tachycardia. They do see orthostatic hypotension, so this is something we might need to keep in mind. Prolongation of the left ventricular ejection time, shortening of the pre-ejection period, and it impaired the sympathetic reflex. But you see, this is in an acute situation, so it augments the synthetic and diminish the parasympathetic, and it's the opposite if it's a chronic use. If it's a chronic use, you'll see more bradycardia compared to the acute tachycardia, but you'll still see the hypotension. And on the sympathetic and parasympathetic, it's the opposite. You can also see an augmentation in blood volume. But they say that with time and with young population, they see tolerance of those effects. So cannabis on cardiovascular, it's another study though, but Wu and Andrew said that the data, it's conflicting. So same thing, we don't have really solid information. But the long-term use, they also say that they see bradycardia and hypotension. They don't know exactly why, but it has been noticed. But they do, according to them, they say that it's rarely clinically relevant, so maybe keep that in mind. Don't like move up your patient too fast, but I don't think it's something that you really need to be worried about. And then again, the only thing is if you have a combination like of cardiovascular patient using regular cannabinoid and you want to do some sedation, they have like high blood pressure, and then you're going to use a lot of epinephrine. So maybe now you can start to think about that a little bit more, and we will discuss that a little bit later. And why, if you're using like a nasal spray too, that can be another risk factor. So, well, let's say it now. So how I would handle those patients if there's a lot of risk factor plus the cannabis use, I would probably first I would reduce the amount of epinephrine to 2 carpule, and if I'm really worried, I will probably monitor my patient, and if I really want to monitor it like a good way, if you have an ECG, then when you inject like your AP, then you'll see the effect. And because the AP doesn't stay for long, sometimes you can use a little bit more if you have a monitored patient, and it's still safe. It's sometimes better than not using enough and patients still have pain, so it can create more stress. So this is how I would enroll my patient with the information that I have here. So, okay, then after that, let's keep going with cannabis and sedation. So the evidence suggests that cannabinoid may interact with the anesthetic that we use and the depressant drug that the patient might potentially take. And they said that you can have a synergistic interaction too. And if you know those interactions, you can use it in your advantage. But at the same time, if you know them, you can prevent like adverse drug reaction. So, okay, another study on Twardowski in 2019. So they did a review of 250 medical records. So they wanted to know what was the effect of cannabis use on sedation requirement for endoscopic procedure. It's an area that, according to them, is for the study again. And their study was criticized by another, not really a study, but a little article that I found that was written by Schimmel and her. They were just criticizing that article. So they said that the methodology was not good, it was a poor study. But that study had the conclusion that the people who regularly use cannabis require an amount of sedation really higher. So let's keep that in mind. Because another study from Hu and Andrew in 2019, they do a review of article 2, and they wanted to see the same thing, the implication of cannabis use on sedation for endoscopic procedure, so really similar. And they said that the literature is not really good, but they found 2 issues with long-term cannabis user. So the first one is that, yes, it does require more sedation. Okay, so this is the same finding that the article that we just saw. And then the second one, we'll talk about it later, is the paradoxic agitation with adjunct of anticholinergic medication. So the first thing they've noticed, and this was an article on mouse model, but there was an interaction with the cannabis and the propofol, which is a drug that our maxillofacial are using pretty regularly. And the THC showed antagonist effect on propofol. So what they had to do to overcome that is to increase the dose of propofol. So if you have a patient that uses a lot of cannabis, expect that you'll need more drugs. And then the second thing was the paradoxic agitation with adjunct of anticholinergic medication. So sometimes, like diphenhydramine, for example, Benadryl, can be used. I don't know if we use it that much. I don't know a lot of maxillo that do use it, but it can be used to avoid the respiratory depression associated with an increase of opioid dose that we need to give for the sedation. But the Benadryl will block the effect of acetylcholine, and the cannabis, like the activation of the cannabinoid receptor, will inhibit the acetylcholine release too. So according to that article, we should really avoid the combination of like diphenhydramine in our sedation, because it can cause like an anticholinergic toxicity. But then after that, cannabis and local anesthesia, which is really more important for us. There's no study about, there's study in medicine, but not that much. And same thing, we'll see if it can help, but I didn't find a lot on that. But they said, and we already mentioned it, it's the THC cause a dose-dependent tachycardia in an acute setting. So then the epinephrine could technically prolong that tachycardia induced by the cannabis. So the cannabis may also interfere with stress response mechanism and cardiovascular. So cross-action between the cannabis and atropine, which is another thing, and epinephrine are possible. So cardiac arrhythmia and syncopal hypotensive episode should be anticipated. You should be ready and maybe enroll your patient the way I proposed, like earlier in the presentation. Now let's just talk about cannabis and drug interaction. So if we are talking about the THC and the medication, so it can be either like it can augment or diminish or lower the concentration either of the THC or the medication in the blood. And it really depends on whether the liver metabolism is inhibited or increased. So it depends which medication. So it can become a bit complicated, but they gave an example. For example, the azote antifungal. I think there's 4 classes of antifungals. So the azole will inhibit the liver metabolism. So if they're using that medication, then it could elevate the THC concentration in the blood. And by the way, it could increase the risk of adverse effects. So then they looked at the CBD, which is another cannabinoid, phytocannabinoid. They said that they also have adversely affect and they affect the liver function. They mentioned some interaction, so maybe with the anticoagulant, it could alter the parameter. With the anti-epileptic, also it can increase their active metabolism and have more adverse effects. So adverse effect could be sedation, sleep disturbance, infection, anemia. So it's not a contraindication, but yes, they could affect. So THC and alcohol, so they both impair cognition and motor coordination. So it's always dose dependent, but they can potentiate the effect of each substance. So keep that in mind. Then THC and CNS depressant, there's 6 classes that have more interaction. So the opioid, the benzo, the barbiturate, anticonvulsivant, antipsychotic, and general anesthetic. So it can potentiate the sedative, the psychomotor, and other effects of the CNS, including respiratory and cardiovascular depression. And then the THC and the sympathomimetic. So I think I mentioned it a little bit earlier, but if you do have either a nasal decongestant or a beta-2 bronchodilatator, those medication could create some vasoconstriction and can cause tachycardia. So if you add it on top of like the epinephrine, the cannabis, and if you have like a cardiac problem, well, maybe you have to start thinking about it. And then after that, the opioid, if you want to give opioid for pain after that, it's only case report, but they say that most of the patient will require higher dose of opioid to achieve like a good analgesia. So keep that in mind too. So to almost conclude, so the patient under the effect of cannabis can have a secondary effect. You can have acute anxiety, dysphoria, psychotic behavior. And if they are using CNS depressant and they come to you and they have used like the cannabis, well, we're just questioning what can they give a valid concept. So I will leave you with that question. And to conclude, I think I said it like during the presentation. I find that the literature on systemic effect of cannabis and oral health is really minimum. There's not a lot of large clinical study, but there's a bit more robust literature on cannabis-induced periodontitis. Well, after all that, that's the end. I think it's a subject a little bit like hard, but it's really do a good review. That I think what you need to know. And if you really want to not know more, but review it, you can read that article that I gave you. So that concludes for me, and I hope my big accent wasn't too bad for you.
Well, thank you so much, Major Grenier. It was an absolutely great, very informative lecture. Just ask for any questions or actually any clinical experiences that that people have had with their patients. Go ahead and put them in the chat. Have you had any experience, or I haven't personally, with patients with cannabis? Yourself, Major Grenier?
Not that much, to be honest. Yeah.
My experience.
I found that I didn't know, like my patient doesn't really, more and more now that it's legal, like it's on the medical questionnaire. But before that, like maybe it did happen, but we kind of didn't know that it was the cause.
Yeah, maybe afterwards they're kind of like, well, it was a little bit high while I was at your appointment before it became legalized.
What?
We're just waiting for a couple more. Any questions? So just to follow up, it was a great, absolutely great presentation. Thank you so much. We've got a few comments about that in the chat. We're going to place the replay online. Obviously, if you're here, you've got it. And then the French version, we're going to have that up soon as well. And all the slides will be available. Major Grenier has emailed them to me, so when I email it the replay information, it'll be available there. So do you have any last points there, Major Grenier?
No, I think I'm good.
All right. Thank you so much, and everyone have a great day.
Perfect. You too. Bye.
Bye.